Okay, so regarding this discussion, actually we are talking about some of the papers like recent advances or the articles which are like fact now. Okay, so again the same issue. 1 minute. Okay, I'll stop the video because the thing is, I will close it over here so that I can talk. Okay, so David Sackett said that half of what you learn at medical school will be either dead wrong or out of date within 5 years. So, and the trouble is that nobody can tell you which half. So research is going on so quickly that within last 5 years you will not be able, the facts which you studied will be not facts later on. Satish, can I ask you a question?
Yes, sir.
You saw calcaneus fracture anywhere in your training? Calcaneum
Yes, sir.
fracture. What type of injury caused calcaneum fracture?
So these injuries are basically caused due to axial loading.
Yes, good. Okay, so high energy axial loading injuries. And do you know what is the classification for it?
Okay. I remember Essex Luprosty classification.
Yes. There is another classification of CT also.
Sanders.
Sanders.
Yes,
okay.
Sir.
Yeah.
Sanders
So when you operate for the calcaneus, there are some principles when you operate for the calcaneus. Okay, I will tell you the principles. The 4 indications are: one is loss of height, second is varus, third is subtalar subluxation or dislocation, and fourth is subfibular impingement. Okay, you are listening to me?
Okay. Yes.
Okay, so these are the 4 indications: loss of height, varus, subtalar subluxation or dislocation, or subfibular impingement. Okay, so Sander classified into 4 types: 1, 2, 3, 4. 1 is undisplaced, 2, 3, 4 are that. Then there are the fracture lines according to the at the facet region on the coronal CT. Okay, so what approach you do for CT scan for the calcaneum ORIF? Anyone can tell me? Lateral or medial?
Lateral L shape, sir.
Yes, lateral. Why you do lateral is it accesses the subtalar and clavicular joint, okay? And
Yes,
it
sir.
helps to do plating. So Sanders is a scientist name. If you remember him, the author noted the distinct learning curve with improved clinical results of type 2 and type 3 fractures in later years of surgical experience. Then he quoted, although anatomical articular reduction is necessary for a good result, it does not guarantee good results. Okay? And he recommended for type 4 fractures, primary arthrodesis. Okay? This is the same Sanders. Buckley, in 2002, he said the best patient to treat non-operative were more than 50 years old, male, those receiving worker compensation, and those whose occupation involved heavy workloading. Okay. Then Folk et al. 2002 again. This is regarding wound complication. He quoted that the smoking, diabetes mellitus, and open fracture increase the risk of wound complications after calcaneal ORIF. So this is you can see the p-values. Diabetes, smoking, and open fractures. This have increased risk of getting open complication wound injuries. Okay, after the surgery. Then you can do percutaneous fixation of calcaneus, and they found the wall in 2010 quoted that there is no difference in need for hardware removal. So the fact is that you don't need to remove the hardware, so percutaneous fixation is almost equivalent enough. And he said that healing time for a calcaneus is 4 months. Okay, and there are low risk of wound infection in the percutaneous fixation if you can do percutaneous. You can hear me, huh?
Yes,
sir.
Yes.
Yeah. So this is 2011, Pontenza, 2011. This is the last article which shows that primary subtalar arthrodesis for Martley community Sander type 4 calcaneus fracture yields good midterm results. So For type 4 Sanders, in exam settings, you can say that I can do primary orthodosis. This is these are review articles if you want to read them. This is a very good, at least the first one, it has a very good explanation of why calcaneus tuberosity fractures occur and how to treat them. Who will tell me what is the sign on this arrow?
This is a Lisfranc injury.
No, but this sign is, what is this sign called?
Sign.
I have put an arrow. So there is some sign
Yes,
in
sir.
it. Who knows the sign? Can somebody tell me? It's okay, no problem. Sometimes no one remembers it. So what do you think? What is this sign called? This white sort of a...
Spike.
No, this is very important in exam. It's called flex sign. Flex sign.
Yes, flexing.
Yeah, so remember the flex sign. Do you know any other findings? What is this, by the way? Lisfranc injury. Huh?
Lisfranc injury.
Lisfranc ligament is between which bones?
Sir, second metatarsal and
Medial cuneiform. Good. Medial
medial
cuneiform.
cuneiform.
Excellent. Okay. So there are two Lisfranc ligament. One is plantar and one is dorsal. Which one is strongest?
Plantar is stronger. Sir.
Plantar is strongest.
Okay. So do you know what are the other radiographic markers for Lisfranc? Okay, I will tell you. One is flex sign, one. Second is this, that the line joining from the lateral aspect of the first metatarsal should cross the medial aspect of the middle cuneiform. Okay. The third sign is that from the medial medial aspect of the fifth metatarsal, if you draw a line, it should cross the cuboid. So it is displaced laterally.
Sir, can you explain the flex sign, sir?
Flex sign, if you see this arrow, this is the
Yes,
avulsion injury of the medial cuneiform. Okay,
Yes, sir.
the bone
Yes.
piece, and it's visible. This is called flex sign.
Okay, sir. Okay.
Okay. What about Jones fracture? Do you know what is Jones fracture?
Yes, sir.
Yes,
It's fifth metatarsal stress fracture. Sir.
Avulsion fracture of fifth metatarsal base.
Yes, fracture.
Okay. Let me explain.
सही है ना
Saudi conduct करा था
Excuse me, who is talking? Ali Muhammad. Excuse me. Ali Muhammad
पसंद
Bhutto.
बगैर होना चाहिए बाकी तो सही रहता है टाइम रखना आज
Okay.
नहीं ना रखूं नहीं
हाँ
Okay. Can you listen to me?
Yes, sir.
Yes,
Yeah.
sir.
I have removed one person. Actually, the Jones fracture are classified. The fracture of the fifth metatarsal are classified into three types. Okay, 1, 2, and 3. One is called avulsion injury. That is avulsion of which muscle? Any idea?
brevis.
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 Brevis. Longest is attached to the first metatarsal. Okay. 2 is metaphysio-diphyseal injury called Jones injury. Okay. Metaphysio-diphyseal fracture of the metatarsal is called Jones fracture. Okay.
Distal to the base.
Yes. Metaphysio-diphyseal is Jones. 3 is diphyseal injury, which is caused by stress fracture. You get me?
Right.
Okay. So actually we have a problem with the changing the screen. Okay. So Mologny et al., this is 2009, he said that early intramedullary screw fixation is safe and effective, results in short time of union and faster return to activity. So in patients who are sport-related, Jones fracture should be fixed. It's better. They will go early for their sports activity. So this is Coetze et al. He said that primary arthrodesis of medial 2 or 3 rays result in better short and medium-term outcome compared to the traditional ORF. We are talking about the Lisfranc injury. How you fix Lisfranc, by the way? Any idea?
Sir, by securing the second metatarsal with the medial cuneiform,
Yes.
and also, sir, a second, sir, a screw fixation or plate fixation from the first metatarsal to the cuboid.
Excellent. And what about the lateral ring? You put a K wire.
Sir,
You do
yeah,
K wire.
K-wire.
You can do
K-wire.
K wire. Why you do K wire? Actually, these things are not in book. These are simple facts. Actually, because the
There's too much space, less space for the implants.
No. You can do fixation. The problem is that there is more movement in the lateral three rays. Okay, so walking will be hampered if your lateral three rays are fixed with screws. So normally it needs
Right,
something like so K wire fixation is better than putting a screw or a plate on lateral aspect. We avoid it. Okay.
Right.
So these are the articles, you can read it. These are simple articles, but some of them are, the fracture and dislocation of the forefoot, this Schenk et al., 1995. It has very beautifully explained all the complications which can come in operative and non-operative fractures. Okay. What is this fracture? Tell us.
Sir, this is the talus neck fracture, sir.
How you classify it?
So by Hawkins classification.
Hawkins.
Hawkins
Yes.
classification for that, sir.
How you
In
classify?
type 1, there is a undisplaced fracture of neck, and type 2 fracture neck talus fracture with subtalar dislocation
Yeah.
or subluxation, and type 3 there is a neck talus neck fracture with ankle dislocation or subluxation,
Yes.
and in type 4 both subluxations.
No. Type 4.
With talonavicular.
Talonavicular. Talonavicular. Type 4 has
Okay.
talonavicular also. That's the thing.
Okay, sir.
So which one has, what is Hawkins sign then? Hawkins sign.
Sir, it
Okay.
is zone of sclerosis within the neck of the talus. It represents the
Subchondral
bone healing, sir.
The viability of the tail neck or talus.
Yeah.
revascularization.
But it's not sclerosis, it's lucency. Check the book.
It's loosened. Sorry. Yes, sir.
It's a
Loosened.
lucency. It's a lucency.
Sclerosis means that the AVN is going to happen.
AVN is present. Yes, sir.
No, not present. Can happen. It's not a surety. If Hawkins sign is negative, this, if not present, this means that there is risk of AVN. This does not mean AVN has happened. Still,
Right.
there is an article for it also that if Hawkins sign is not a must, but Hawkins give you a satisfaction that yes, this is alive, the bone is alive. Lucency occurs when the fracture is fixed and there is blood supply.
The sign of revascularization.
Yes. Okay. So this is the article 1970, Taylor neck lucency. So Hawkins explained that to assess the talar vascularity between 6 to 8 weeks, you should do a radiograph, non-weight bearing, and it should show disuse atrophy. And this absence of subchondral atrophy, this lucency means that there is still blood supply. And subchondral atrophy excludes the diagnosis of AVN because bone must be vascularized in order to undergo disuse osteoporosis, resorption, sorry. So this what word should I use that he was the one who gave the name Hawkins sign. Okay, 1970. So this is Valliere et al. He showed that overall AVN rate was 49% in all talus fractures. He showed that in type 2 fracture AVN rate is 39%, type 3 fracture AVN rate is 64%, and type 4 interestingly has rate of AVN of 20%. This is different from the book, by the way. So AVN was associated with talar neck comminution and open fracture. Okay, he said that urgent reduction or dislocation is important and treatment of open injuries, but delaying definite rigid fixation until and unless soft tissue swelling has subsided in order to minimize soft tissue complications. This is different. Before 2000, they were fixing everything. Talus comes, it's emergency, just fix it. He said no, reduce the dislocation and wait till the swelling in the subcutaneous tissue and the skin compromise is resolved and then fix it. So nowadays we do what Valliere found in 2004 in his article. We reduce the talus and we do operative intervention if the soft tissue swelling, there is no soft tissue swelling, we go for surgery. Otherwise, we delay definitive rigid fixation. Who will tell me what is this? This is pilon, it's written over it. So what is the principle of pilon fracture fixation? Whenever you fix any fracture, there should be a principle to fix it.
Sir, ideally should be anatomical reduction, sir.
Okay, 1, 2,
Stable fixation
okay. Let's take this also.
and preservation of the blood supply. Restoration of the articular surface. Absolute reduction.
Okay. Now you are going haphazard. There are
And,
four principles. AO principles are 4 in this.
Yes.
First is
Anatomical reduction.
maintain the length. No, maintain the length. How you maintain the length? You fix the fibula.
Fibula.
Okay. Second, you fix the fracture. The tibia fracture, which is the main fracture, you fix it. Third, bone grafting. Metaphyseal comminution should be either not opened or you do bone graft in it. And fourth, intra-articular reduction. Perfect intra-articular reduction should be achieved. These are the 4 principles. Okay, remember this because they will ask you in exam. These things they will always ask you what are the principles for fixation of this fracture. So if you tell him you fix the fibula, he will tell you for what. So you have to tell him that fixation of fibula because I want to maintain the length. Second is intra-articular congruity to be maintained. Third, fixation of the fracture, the metaphyseal comminution, I need to fix it some way. Fourth, bone grafting.
Right.
So this is a classic paper of Rudy Al Gore, 1969. And this is where he explained that these things should be done. So the author concluded that high energy, high percentage of good functional results supporting achieving optimal anatomical reduction. The critic was that most of his patients were low energy patients, had low energy. These are the complications which he showed up. But he said that he wrote here that 90% were able to return to the same occupation, which is now refuted already by new articles. Most of the patients don't do well. This is the article of Serkin. This is article which showed state protocol for soft tissue management in the treatment of complex pilon fracture, 1999. Since then, these 4 principles have been like part of fixation, part of the plan of management of pilon fractures. Look at this. He said that protocol consists of immediate within 24 hours ORI of fibula and application of spanning external fixator. Later on, ORI of tibia after a lag of 4 to 14 days. Average time for external fixator, 14 days. 2 cases developed partial thickness wound necrosis. Both were treated successfully with local wound care. 1 case developed wound dehiscence. 1 case with ipsilateral continued calcaneal fracture developed severe osteomyelitis. The result compared favorably with the
Excuse me, sir?
Yes.
Dr. Ali is requesting to join again.
I cannot join. I cannot join. He was talking, so I cannot join. Please, I cannot join him.
Okay.
Even if I try, I cannot join him. Tell him I'm sorry.
Okay.
Yeah.
Okay.
The author concluded that the high rate of complication associated with tibial pilon ORIF was due to early operative treatment through swollen, compromised soft tissues. The stage protocol present in this paper and commonly used today until now significantly decreased the complication rate associated with tibial pilon fracture. So whenever in exam you can quote this paper, and even up till now, like last 20 years, we have been doing the same for pilon fractures. Unless he comes on the same date, like the patient after the pilon fracture directly come to you and you are going for the OR within 4 hours and you keep him, and the patient is NPO also, so you can do definitive fixation, no problem. But otherwise, most of them are staged. This is another 1996 prospective study, and the investigator concluded that external fixation is a satisfactory method for tibial pilon fracture and is associated with fewer complication rate than ORIF. This is the only article 2010 which shows non-stage pilon ORF. Only one article in the whole last 20 years, only one article is saying that non-stage should be done directly operative. Anatomic reduction 90% cases is possible. The investigators concluded that when surgery is performed expeditiously by experienced trauma surgeon, most tibial pelon fractures can be treated with primary ORF. Most have educated stage surgery except this study. I wrote it down because you should remember it. This is Wang et al. Comparison of two-stage ORIF with limited internal fixation with external fixator for closed tibial plafond fractures. Limited internal fixation with external fixator is associated with higher rate of superficial infections, primary pin tract infection, but this does not affect the final outcome. He's saying that external fixator will cause pin tract infections and these things, but and resultant, the patient will still, this will not affect his outcome. This is Polak in 2003. He said high energy tibial peroneal fracture outcomes. Regarding this, he discussed that investigators conclude that the patients sustaining tibial peroneal fractures suffer persistent and devastating consequences of his general health and well-being. And they do, 68% will not work the same job. And this is like, nowadays, most of people agree that peroneal fractures, the patient will not come back to the same level. It's not possible. These are review articles. I have not read all of them, but you can have a look into it. Actually, here I'm talking about syndesmosis. How many screw you will fix with syndesmosis? Anyone has an idea? 1, 2, or 3?
Sir, a single cortex screw.
One cortex.
Two,
How many cortex?
Sir, three cortices.
Three cortex, sir.
Why not 4? Why not 4?
Because when there is dorsiflexion of the ankle, it will cut through.
Okay. Who is this, by the way? Who is talking to me?
I am Dr. Abid from
Dr.
Lahore.
Abid. Dr. Abid, yes. In your exam, you will tell that dorsiflexion will do. Actually, when you dorsiflex the foot, the talus is broader on dorsiflexion. Anteriorly, it's broader. So what they say is when you dorsiflex, it can cut out. But actually, this has been refuted already. Since last 2-3 years, they say that dorsiflexion does not cause anything. But it does not cause any problem. But the thing is, on the exam, you can tell him, he will be happy. But still, this is 1976 Ramsey, and this will be asking questions. This paper is that changes in tibutalar area of contact caused by lateral talar shift, 1976. And this has been tested. 42% average decrease in contact area with a 1 mm of lateral talar shift. This came in my MCQs also. So 42% decrease in contact area with 1 mm of lateral talar shift. When the contact area is decreased, the load per unit area is increased. So there are more chances the patient will go into osteoarthritis. Because stress per unit area increases as the total contact area decreases, the decrease in tibutalar contact area may contribute to poor outcomes following ankle fractures when lateral talar displacement is more than 1 mm. So you it anatomically. This is Vilroy et al. 2000. No difference in functional and radiographic results 8.4 years after quadricortical compared to tricortical syndesmosis fixation in ankle fractures. 8.4 years, by the way, it's enough that he has said that there is no difference in tricortical or quadricortical. Both tricortical and quadricortical syndesmotic fixation shows satisfactory functional results. Obese patients have significantly poor results. Difference in syndesmotic width of 1.5 mm or greater than 2 ankles seem to be associated with inferior clinical results. So again, there is Hoynes 2007, tricortical versus quadricortical syndesmosis fixation ankle fracture with syndesmosis. At 3 months, pain was significantly lower in tricortical group. So he is supporting you. Hoynes 2007 is supporting you that within 3 months, tricortical works well. But at 1 year, there is no significant difference in the pain between the two groups. No significant difference in dorsiflexion between the group at any time point, as I told you previously. So if you did a fixation of ankle, what you will do? You will do a cast or a brace?
We'll do a cast.
Is it important to
Cast.
cast?
Back slab, sir. For fibula fixation, sir, it's not a stable fixation.
Yeah, it can be stable. Why not? But still, you will do cast or back slap. Cast or sorry, ankle brace. Okay, this is the answer over here. You are right. Back slap is better. I will show you the answer.
Yes.
This is Latton in 2003. Cast compared with functional ankle brace after operative treatment of ankle fracture. No perioperative complication either group, so it does not matter. But he said significantly most post-op complication in the functional brace group, and common complication was infection, superficial and then deep. So there, we cannot explain why infection is more in a brace. I'm not sure why, but yes, you can put a back slap and you can support it by this. These are another review articles which you can, if you want to read. So, 1 second. So this is tibia. We will talk about some articles.
Yes, sir.
Okay. This is top-cited paper. By Bone LB 1994, his prospective study of union rate of open tibial fractures treated with locked and unreamed intramedullary nails. So he quoted that average time of union is 148 days. So probably 5 months. Author concluded that unreamed nailing did not improve union rates compared to the historical rate of external fixation. Actually, this article is discussing the open fractures, tibia, comparing the unreamed nail with external fixator at that time, 1994. And he quoted that does not matter, external fixator or unreamed nail does not improve the union rates. So if we put it into external fixator, it does not matter. It has the same results. What is this?
This is PTB cast.
PTB.
Okay.
Patellar
Do you know-
tendon bearing.
Do you know
Patellar tendon bearing.
Yeah, but do you know who devised this concept? PTB cast?
Sarmiento, sir.
Sarmento. So Sarmento 2004, this is a like 450 closed fractures of distal third tibia treated with functional brace. And he found that 90% of the patient healed with less than 8 degrees of angular deformity in either frontal or sagittal plane. He also put that final shortening was essentially unchanged from initial shortening at the time of injury. So the amount of shortening you have after the patient had a fracture, it will remain the same. So conclusion of the functional braces for treatment of closed tibial distal third fracture is a viable approach that offers satisfactory clinical and radiographic results in high percentage of instances. This is Bhandari. By the way, I want to tell you something. If you have not read articles, this guy is amazing. This Bhandari, most of his papers are top-cited. He is a very renowned research personality. So, regarding predictors of reoperation following operative management of fracture of tibial shaft. So, why you reoperate a patient with tibial shaft fractures? 3 variables, he said. First, presence of open fracture. Second, lack of cortical continuity. Third, presence of a transverse fracture. So these are the factors, prognostic variables, which can assist the surgeon in predicting reoperation following operative treatment of tibial shaft fractures. For example, if you have a patient which has a transverse fracture, it is more riskier than a spiral or oblique fracture. Lack of cortical continuity, it increases the risk of reoperation. In the presence of open fracture, there are more chances that it should have more intervention. It will need another intervention. So surgeons should avoid distraction at the fracture site. The one variable that is under surgeon's control, whenever possible, the treatment of tibial shaft fractures. This is Valiar in 2011 compared plate versus IM nailing for distal tibia shaft fractures. So he quoted that both non-lock plating and reamed iron nailing have higher primary union rates in distal tibial shaft fractures. The rate of infection, non-union and secondary procedure are similar. But he quoted fibular fixation may facilitate better reduction of tibia at the time of surgery, but further studies warranted. If you note this over here, iron nailing was associated with more malalignment. If I put a nail for a tibia fracture, how the bone will heal? Primary or secondary?
Second intention.
Secondary, sir.
Why?
So
There is a sir, dynamic relative stability. Sir.
It's a relatively stable. What about plate?
there is an
It's absolute,
absolute.
sir.
It's absolute stable implant and there is no callus formation. What is this? Who knows it?
Knee
this is
dislocation.
knee,
The
posterior
lateral
knee
dislocation of the knee
dislocation.
joint.
Which side? What do you think? It's the posterior medial or posterior lateral?
Posterior medial.
Needs another view.
I
Needs another view.
Lateral,
Posterior medial.
posterior medial.
It's the posterior medial.
No, sir. In knee, dislocation is defined with the translation of the tibia, not the
Tibia.
femur.
So tibia. So what is this? Just see.
It's a posterior medial tibia.
So it's posterior
It's
medial or posterior lateral?
For the
Posterior medial.
posterior, we have to take we have to look for another view.
Looks like
Yes.
posterior.
It's a posterior medial.
Don't complicate yourself. What is this? Posterior medial? Oh, medial or lateral? Just leave it.
Medial.
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 So medial. It is posterior medial, by the way. How you
Yes,
classify
yes,
it, by the way?
The Shenek classification,
You
but
know what is Shenek? One is either ACL or PCL is intact. Okay.
yes, yes,
Two
yes,
is as both torn. You can remember it like type 2, ACL, PCL torn.
Yes.
Okay. 3 is a ACL, PCL plus posterior medial corner or posterior lateral corner. Okay. 4 is 4 torn. ACL, PCL, posterior medial corner, posterior lateral corner. 5 is frank dislocation.
Shank classification.
So how, if you have a fracture you have a dislocation, knee dislocation in the ER, how will you reduce it? What you will do, first step.
First of we will go for reduction.
You will not examine the patient?
No,
Sir, I
ATLS.
will
ATLS
I will
first.
examine.
Status.
Okay. And then?
I
ATLS
will
done.
go for the neurovascular status of the patient.
Okay. Okay. No pulsation. Now?
Now, sir, I will
If there
reduce
is
that.
no pulsation, I will go for the reduction first.
Okay.
Then I will
Analgesia,
check
sedation.
for it.
Analgesia and sedate him.
Yes. Okay. Okay. Except both of them are right. So you reduce it and then you do selective angiography. You don't do, every patient is not for angiography suit. The patient which is after the reduction, still there is vascular deficit and ankle brachial index is less than 0.9, then you go for angiography. Otherwise, you proceed for reduction of dislocation first. So, Kennedy, I'm not sure about the year because I missed it, I think so. It's complete dislocation of the knee, order of structure injury in the anterior dislocation, which is more common. First, he said that the posterior capsule injury occurs at the average 30 degree of hyperextension. Then PCL tear up, then popliteal artery, okay, and popliteal artery rupture occurred in the average of 50 degree of hyperextension. Okay. Posterior dislocation are harder to create and require greater torques. This is cadaveric study probably. And associated vascular or nerve injuries occur in more than 50% of the patients. Early vascular exploration is mandatory when there is suspicion of vascular injury. Simple treatment of uncomplicated cases may produce surprisingly good results. And he advocated early repair of major ligaments result in a useful knee. This is Tweddle et al. 2003. 63 cases of complete dislocation. He said frequency of ligamentous injury: 84% ACL, 87% PCL, 71% ACL and PCL, 44% MCL, and 62% LCL. So most common injuries ACL and PCL. This is Stenard, and this is the study which shifted our plan of management. Previously, most of the patients used to go for angiography suits. So Stenard 2004, this study was the shift from arteriogram to physical examination. He quoted that vascular injuries in knee dislocation, the role of physical examination determining the need for arteriography. So he quoted that indication of arteriography is decreased pedal pulse, lower extremity color or temperature change, expanding hematoma above the knee, and history of abnormal physical examination prior to presentation. His conclusions were selective angiography based on serial physical examination is a safe and prudent policy following knee dislocation. There is a strong correlation between knee physical examination results and need for arteriography. Increased vigilance may be justified in patients with KD4, dislocation treated with tear of both PCL and posterior and posterior corner, for whom serial examination should continue for at least 48 hours. Who will tell me why 48 hours?
Because intimal tears mostly.
Very good, very good. Intimal tear. Most of them are intimal tears. So you have to admit them and keep him admitted for 48 hours to assess if there is any deterioration. So most of them are not complete tears. They are intimal tears, and it can progress. That's why you have to admit the patient and for 2 days. This is I took it from Miller. And if you see the apparent knee dislocation, you have to physically examine. If it's absent, pedal pulsation absent, reduce the dislocation first and then reassess the pulsations. So if this patient comes with a polytrauma, what you will do?
Then fix it.
Fix what to fix? Like how to fix? Polytrauma. He had a fractured tibia,
Sir,
fractured femur, bilateral fracture humerus,
yes.
and clavicle fracture also. Tell me what you will fix. And how you will fix. And any idea?
So first of all, according to the ADLS protocol,
ATL is done vitally stable. Vital blood pressure is 100/70.
Okay.
Secondary assessment showed urine output of like 28 ml per hour. So now what you will do?
We can go with an external fixator for the femur or an unreeved nail.
How will you decide? Scientifically, how will you decide? This is a good question. Scientifically, you will examine the patient. I told you output. Output is okay. For example, 28 ml. 28 ml
Yes.
per hour.
The kidney is okay.
Okay, the kidneys are okay. What else you want to know?
Status of the lungs. Saturation.
I did the chest exercise. Chest is normal. Then
Sir, I will go for the D timer to check for the
pulmonary embolism. You are suspecting pulmonary embolism? Negative. D dimer is positive, but the doctor is negative. Let's take it negative.
Age.
What about
Age and condition?
Have you heard about lactate, base deficit, transportation oxygen measurement, these things? You remember? You have heard about these things?
Yes. Yes.
Okay.
Yes.
That's what I was telling that you won't practice. We don't practice, so we don't know. So you do ABGs. So if serum lactate is less than 2, so how will you fix it? You will definitely you can do definitive fixation in this patient if less than 2. Okay. If the If the serum lactate is 2 to 2.5, you do damage control surgery. Okay. And if lactate is more than 2.5, what you will do? You will shift the patient back to ICU. You are not operating on this patient.
Okay.
So,
Right.
so less than 2, I will do definitive fixation. 2 to 2.5, I will do damage control surgery. More than 2.5, I will shift the patient to ICU. This patient is not stable enough for OR. Okay. So, this is bone LB. This is a randomized controlled trial, landmark studies 1996. He compared early versus delayed stabilization of femoral fractures. So he quoted early stabilization decreases pulmonary complications. Okay. So it reduces the risk of ARDS, pulmonary dysfunctions, fat embolism, abnormal ABGs, pulmonary embolism. And so he quoted that any polytrauma patient early stabilization is better than delaying it. Before this study, we were putting external traction pins for every patient. Are you getting me? We were not fixing it. We were putting external skeletal traction and okay, admit the patient and let it be for 1 week. Because the thing is, if we operate on them now, they will die. So he quoted that no, you should fix these fractures because of decreasing the risk. If it is not a polytrauma, it's a single isolated fracture femur, you better fix it as early as possible within 24 to 48 hours. So the author provided the overwhelming recommendation that early stabilization of long bone fractures should be performed in multiple injury patients. When early stabilization of long bone fracture is done in conjunction with early intubation, ventilatory support, and proper management of fluids, the rate of pulmonary failure in these patients is drastically reduced and will lead to dramatic savings. Prior to this study, patients were treated with traction, often leading to deterioration of their condition and even death. While randomized trials are now common, this was rare in orthopedic study at that time. This was a landmark study because RCT trials are the best trials. So this was I think the very the very beginning of RCT trials in orthopedic. Previously that it was not common. This is Nowatarski in 2000. He said conversion of, okay, I want to ask you something. Femur fracture, I put external fixator, when you will nail it? When you change into nail?
Sir, after 3 weeks, sir.
Why 3 weeks? Why not 2 weeks?
Yes. No.
Within 2 weeks.
Sir, when
Okay.
there's
Checking-
soft tissue coverage,
After checking the
Contact infection.
lactates.
of the soft tissue, when the soft tissue coverage is proper, sir, and is covering the bone, then we can do.
Okay, that's okay. That's okay. That's your protocol. You remove the external fixator and put a skeletal traction and shift the patient to the home and let him come when the wound is healed and you will put a nail. That is your protocol. But I want to change the IM nail, remove the pin in the OR and put a nail directly. I want to remove the shunt pin and put a nail in directly. So this can be done within 2 weeks. That's it. After that, there are more chances of infection. So this is the guy, Nowatarski, 2000. He showed that conversion of external fixator to IM nailing of fracture shaft of femur in multiple injury patients. He said average time in X-fix prior to nailing was 10 days and 97% healed within 6 months. And he quoted that while it remains unknown how long external fixation can be safe before there is increase of infection risk. But in his study, he did conversion within 2 weeks and the results were excellent. So he said within 2 weeks you can convert it. So you put external fixator, within 10 days the patient is fine now, the serum lactate, base deficit, everything is okay. So you shift him to the OR, remove the shunt pin and directly put a nail in. It will not cause infections. This is BOSS 1997, adult respiratory distress syndrome, pneumonia and mortality following thoracic injury and femoral fracture treated either with IM nailing, with reaming or with plating, a comparative study. So he's quoted that IM nailing with reaming for acute stabilization of femur in polytrauma thoracic injury does not increase the occurrence of ARDS, pulmonary embolism, failure of multiple organs, pneumonia, or death. Before this, we were doing unrimmed nails to avoid ARDS. Okay. So after this study, the guy quoted that you can ream the nail, you can put a ream nail and will not cause ARDS unless you take care of the other markers like the base deficit, urine output, vitals, and these things. So it will not cause second hit. These are some review articles. What is this? Who will tell me? What is this?
This is tip to apex distance
Tip apex.
while doing
How much it should be?
EHS.
less than 25 mm. It
Sir,
should be
0.5 to 1 centimeter.
Don't say this, the centimeters. Just say 25 mm. Less than 25 mm. So
In
if a
both,
patient, huh?
Both AP and lateral.
in both
Yes.
views, sir. AP and lateral view.
Yeah, but how much it should be? Less than 25 mm.
Yes.
Yes, sir.
25.
This was shown by Baumgartner in 1997. He said the value of tip apex index is predicting failure of fixation of peritrochanteric fracture of hip. Average TAD in cases with screw cutout was 33 mm. Average TAD in case without screw cutout was 24 mm. So he said that below 25 mm, you should aim for this. So this guy also quoted some factors. He quoted the chances of failure of the reduction or implant, and he said that if tip apex index is more than 30 mm, it will fail. If there is an unstable fracture, it will fail. If the age is more than 76, it will fail. Or plate angle is more than 150, it can fail. So how will you fix, who will tell me, I have a patient of 80 years old, okay, non-diabetic, non-hypertensive, walking without any stick, had a neck or femur fracture. What will I do?
So,
Calendar scale.
we go for total hip orthoplasty, primary total hip orthoplasty.
Total hip arthroplasty. Okay.
Duration of injury.
What?
I would
Because
like
of
to,
his physiological
I
age,
would like
sir,
to fix
he's
that fracture
mobilized.
using cannulated screws.
You can reduce. 80 years old female will not survive if there is a displaced neck or femur fracture. It will not. It is of no use. For example, I will ask you another question now. It's an 80 years old female with a fractured neck or femur displaced. Previous history when I asked, she was walking with a stick. Now what you will do?
Hemiarthroplasty, sir.
Hemiarthroplasty.
is okay.
Why?
If
I would like to
ACWM is okay.
using total arthroplasty.
This is not
Because
answer.
of the-
Hemi or total hip arth. This is not answer. In your exam, this is not answer. In your exam, it will be hemiarthroplasty. Why? Actually, in the clinic scenarios, you can assess and patient and decide to go for total hip or hemiarthroplasty. But for 80 years old walking with a stick, this means that she has already weakness.
Hemiarthroplasty.
She's already
Yes,
using
and
a stick.
keeping the
She has already
life expectancy in mind.
abductor weakness. Okay, so it's more chances to give a hemiarthroplasty for a patient with abductor weakness. And for example, the same patient is without a stick, walking ambulatory, normal community ambulance, 80 years old. I will go for total hip replacement. Okay, for the same patient, if the patient has a Schleimer disease, then what you will do? A Schleimer disease.
Yes, Alzheimer's. We can go for
Hemiarthroplasty.
More chances that he will go for.
fixation, the osteosynthesis.
No, you cannot.
I will go for the
80 years old.
This is
female.
hemiarthroplasty, sir.
Or we
I
can
would
go for
the section arthroplasty, sir.
Is the patient is he mobile or non-mobile?
Okay, 1 minute. In your exam, never say resection arthroplasty. Never say. Yeah, in exam, 80 years old female at Schleimer, the patient will more go for hemiarthroplasty than total hip replacement. More towards hemiarthroplasty.
What about arthrodesis?
No, I don't think arthrodesis will be the.
Your arthrodesis for a young patient who is a labor. That's it, done. Just it.
Right.
Don't decide on hemiarthro. He will ask you why you want to arthrodesis. You will tell them that this will give buy time so that I can do total hip replacement. The patient will, the doctor will ask you, like the patient is 80 years old. You want her to be crossing 100 for total hip replacement. So if any patient with displaced neck or femur fracture above 60, you can go for total hip replacement depending on the patient's general condition. If the patient is walking with a stick, having a Schleimer disease, or the patient is having neuromuscular disease or something else, I will go for hemiarthroplasty. Otherwise, the patient is community ambulant, above 60, neck or femur displaced, recommendation is to go for total hip replacement. So this is the patient, I told you this guy, Bandari, 2008 neck or femur fracture in elderly. Internal fixation compared with arthroplasty for displaced fracture of femoral neck. He quoted that mortality rates in 1162 patients provide detailed information on mortality rates during the first 4 post-op months. Mortality rate was 0 to 20%. There was a trend towards an increase in the relative risk in the first 4 months after arthroplasty compared to internal fixation. Treatment of displaced femur neck fractures by arthroplasty significantly reduces revision surgery, but at the cost of greater infection rate, blood loss, and operative time, and possibly an increase in early mortality even. So these patients are high risk for mortality also. Taylor, 2012, hemiarthroplasty of the hip with or without cement. Who will tell me? Your patient decide. You decide the patient will go for hemiarthroplasty. Neck or femur fracture. You will go for cemented or non-cemented?
I will go for cemented hemiarthroplasty, sir, due to osteoporotic nature of the bone.
Yeah, so this guy, Taylor, in 2012, concluded that both cemented and uncemented processes provide comparable outcomes in terms of pain. There is significantly fewer implant complication when you use cemented hemiarthroplasty implant. There is a trend towards better function and mobility in patients treated with cemented arthroplasty. Okay, this is I didn't show up the X-ray distal radius fracture. It's in 1986. Actually, this was a time that percutaneous fixation was in a common occurrence. Like he was doing, this remains a classical paper that details the critical importance of reduction of good functional outcome in young patients. When the surgical technique has advanced since the time of this article, most frequent internal fixation. The observation and conclusion of this article remains valid. Before this, we were doing conservative reductions. You will reduce the fracture, put up the cast, and then let's shift patient. So this was the beginning that he was the one who quoted that operative intervention is better than the conservative management. So he quoted prognostic factors that influence development of post-traumatic arthritis. Failure to obtain or maintain articular incongruity, 1. 2. Initial disruption. 3. Dorsal angulation or radial length. 4th, maintenance of final reduction. So after this, we start doing operative intervention for distal radius fractures. This was a percutaneous fixation by Kreder et al. 2005. He quoted that indirect reduction and percutaneous fixation versus ORA for displaced intra-articular fracture distal radius fractures. So at 6 months, he found better OLR function in indirect percutaneous reduction and external fixation there. However, at 12 and 24 months, there was no difference in the upper limb scores. So you can do percutaneous or you can do open. You can put an external fixator unless you have reduced the intra-articular fragment in a perfect way. This is IKEDA. If patient comes with a nascent type 3 fracture in an adult population with fracture dislocation, what you will do? You will excise the radial head or you will keep it?
We'll excise the radial head and replace it with metal prosthesis.
Sir, we'll reduce the larger fragments, sir.
Okay, for example, you cannot reduce.
Sir,
And you will never. Okay, yeah, you are right. You are right. You will excise. You will put a hemi implant. If you don't have implant, you will keep the same. You will not excise it only. You get me?
Right.
Yeah. So Ikeda in 2005 communicated fracture of radial head. His comparison of resection and internal fixation. Resection or interval. So all Mason type 3 fractures, ORF is treatment of choice when feasible. ORF group had satisfactory joint motion with greater strength and better function than patient treated with radial head excision. One major limitation of this paper was the marked difference in follow-up between the two groups. Actually, in exam, they will ask you, there is a fracture, 5 fragments of a radial head, and I'm in the OR with you, I'm your assistant, and go tell me, you will excise it, you will do what with this? What approach you will use? So you will do the approach, he will explain. After that, he will ask you whether there is no implant with us. So you want to excise it or fix it, or what you want? He said, I want to fix it.
Yes,
Okay.
sir.
Not possible to fix. Now what you will do? So you will not.
I will excise it if implant is not available.
You will not
Implant is not
excise.
available.
You will not excise.
Okay.
Don't
No.
excise. Okay? Because being safe practice is better than doing something which is not indicated. If a
Okay.
radial head fracture comes and you excise it, what can happen?
There is a
Of the radial head. Proximal migration of the
Someone, I heard
SX
something.
loop C.
Yeah,
SX loop.
it can end up to distal radioulnar joint instability as SX is suppressed. So we better keep it. And we'll excise it later on, no problem. But not at that time. Okay,
No.
this is Ring et al. 2002, open reduction and internal fixation of radial head. He quoted that ORF is best reserved for minimally comminuted fracture with 3 or fewer fragments. Okay, associated fracture dislocation of the elbow or forearm may also compromise the long-term result of radial head repair, especially with regard to restoration of forearm rotation. These are the review articles. Okay, this is olecranon fracture. So, can someone tell me, if a patient comes of 2 years of age and has a olecranon fracture, what are your concerns? 2 years, age of 2 years only. Okay, a patient of this age, 2 years, comes with olecranon fracture, you should exclude what? What disease you should exclude? Any idea?
No idea, sir.
Okay. Any olecranon fracture in a pediatric population, you should exclude.
Child abuse.
Child abuse.
Yes. And then second is osteogenesis imperfecta. Try to read the book. In the book, it's written. It's from the book. A pediatric population, if have a olecranon fracture, we should exclude in these patients osteogenesis imperfecta because the incidence of olecranon fracture is more common in OI. Okay, who will tell me tension band wire in this case is better or plating?
Sir, as the fracture is oblique one, so I would prefer the plate fixation in this fracture.
When you will decide to do tension band wire, then?
Right.
When there is a simple transverse fracture of the olecranon.
Sir, simple fracture without intra-articular fragment. There is no combination.
Simple-
Attention
This is
band
Simple
wiring.
transfer fracture.
This is not
Simple
simple.
transverse fracture.
This is not simple.
This is simple, but this is oblique, sir.
I can do tension band wire in this and it will be fine. No problem.
It can
Hello?
be stabilized with TBW.
This can be stabilized with TBW. No problem. But
Yes, sir.
what,
Yes.
what fracture you will fix with plate, for example? Let's change it.
Yes.
Which fracture you will put a plate?
Community.
If
Oblique
there
fracture.
is-
No, one person. Okay, Mohsen, now you start telling me.
So it can be
Community.
oblique fracture, community fracture.
Okay. Another. Third, I will tell you, extending below the coronoid. The fracture which is extending below the coronoid,
Okay.
you cannot fix it with a tension band.
Right.
So, Exact. Okay. So this guy, Hume et al. 1992, he compared the clinical and radiographic comparison of tension band wiring with plate fixation. So he quoted that longer operative time is needed for plate fixation, but there is no significant difference in elbow motion between the two groups. The TBW, there is more symptomatic hardware than plate. And post-op, loss of reduction leading to a significant articular step-off or gap, 53% in TBW and 5% in ORIF. So the author recommended that plate fixation should be strongly considered when planning ORIF for displaced olecranon fracture. In this study, plate fixation resulted in more anatomical reduction and better maintenance of reduction. The author noted the importance of placing the tension band wire deep to the tricep tendon and on the periosteum of the olecranon and bending the proximal end of the KY 180 degree and inserting them flush into the cortex of the proximal fragment. In this paper, he wrote that I'm not supporting plating. He's saying that actually I'm just giving you the information. But in that tension band wire, he showed that it should be embedded inside the tricep. Before in 80s, they was doing tension band wire, but they were not embedding it. Okay. Are you there?
If we embed in the tricep, what is the advantage?
It will not be prominent. That's the only advantage.
Okay.
Okay. Childs 2008. Is tension band wiring technique the gold standard for the treatment of olecranon fracture? It's a long-term functional outcome study. He quoted that male 5th decade and female 6th decade is the most common incidence of this fracture. And 61% are due to simple falls, 39% are due to high energy injuries, and supination was more effective than pronation. Author concluded that tension band wiring fixation remains the gold standard for the treatment of displaced fracture and minimally comminuted, as Satish said. If there is comminution, you go for plate. This is Maripuri, in 2007, simple elbow dislocation among adults, a comparative study between two different treatment methods, splint for 2 weeks, followed by physical therapy. So he said the early active mobilization is safe and cost-effective method for treatment. Early active mobilization results in significant better final outcome. So in elbow dislocation, if a patient, they give you a scenario, you will tell him that I will immobilize him just for 2 weeks in an arm sling. You will not tell him 3-4 weeks. Because this paper is now already in the book. So it is now like a known fact. Now it's not when I was in training in 2010, I was asked by my professor this, and I told him 4 weeks, and he said, no, 2 weeks.
Yes.
So now it's a known fact that you should immobilize the patient only for 2 weeks and start mobilization. Early active range of motion. Okay?
Upper limb for 4 weeks, 2 weeks.
2 weeks, not for 4 weeks. Okay. This
Sir, one question here. Sir, when we have an oblique fracture of the olecranon, what will you prefer, either tension band or plate fixation, sir?
It depends on the fracture. I told you one thing. If the fracture is extending below the coronoid, I will fix with the plate. That's it. You get me?
Right, sir.
Check the book. In Campbell, I'm not sure about your textbook, Campbell, 13th edition. But if the fracture is below the coronoid, it is unstable. If it's comminuted, it's unstable. So I will push to the plate. Otherwise, most of them, I will go for a plate. Tension band wiring.
Right, sir.
This ORF versus total elbow arthroplasty for displaced intra-articular distal humerus fracture in adults. And he said that total elbow arthroplasty is preferred alternative for ORF in elderly patient with complex distal humeral fracture that are not amenable for stable fixation. They will not ask you this question. Who will tell me? Humerus, what are the indication for non-operative fixation? How much angulation acceptable?
Sir, 30 degrees in the coronal plane.
Okay,
Less than 45 degrees.
20 degrees in the sagittal plane.
Yeah, Satish is right, Mohsin. It is not proximal humerus. It is clinical. Look at it's like a diaphyseal fracture. So 30 degree in the coronal plane and 20 degree in the EP. And how much shortening, Satish? How?
Less than 3 centimeters.
Very good. Yes, very good. So when you will operate for this? Satish, I am asking
Sir,
you.
yes, sir. I'll operate when there is an open fracture.
Okay.
When there is associated vascular injury.
Okay.
When we are unable to do the close reduction of the fracture.
This is not indication. Okay. Then more.
When these non-operative parameters are not met.
When we have multiply injured patients, just like a patient having ipsilateral forearm fracture.
Floating elbow. Okay.
Floating elbow.
Yes. Bilateral humerus shape fracture.
Humerus fracture. If there is after reduction, if there is nerve injury, and we have to get it open and look for any impingement or entrapment.
This is not by the way.
Absolute.
This is not absolute indication. So the indication is one is open. Okay, I accept it. Second is floating elbow. Third is polytrauma. Fourth is pathological.
Yes.
Fifth is brachial plexus injury. Not nerve injury, brachial plexus injury.
Okay.
So
Sir,
this
what
is
about massive obesity?
what?
Obesity, sir, massive obesity or females with very large.
These are relative indications, Abid. These are all relative indications. Obesity, large breasts, and patient has bilateral, like the patient is unable, wants to be having like bilateral femur fracture or femur fracture, associated lower limb fractures. Ambulation is important, but these are indications: open, floating, polytrauma, pathological, breaking. That's it. You will not say radial nerve. You will not say radial nerve.
Yes.
Okay. So this is landmark study was Sarmento. So he quoted that functional bracing fracture of humerus, shaft of humerus fractures, and he quoted 98% union. Shakir, Dr. Shakir. I think there is some problem. So 98% union is achieved by functional cast brace. Okay. So he quoted that functional bracing provides a hydraulic compressive centripetal force that maintains the fracture alignment. Okay. This landmark article provided the gold standard against which operative fixation has been judged now. Okay. This is again Sarmento 1990. He quoted that functional bracing of comminuted extra-articular distal third humerus fractures, 96% of the patients, the fracture will unite. Okay. He also quoted, Abid, I will answer your question. The author concluded that the prefabricated brace provides satisfactory result of comminuted extra-articular distal third fracture. He also noted the high rate of nerve recovery and indicated that early exploration of the nerve is not justified. This is Chapman 2000. Who will tell me upper limb, plate is better or nail is better?
Plate is better, sir.
Why?
Plate is better.
Nailing causes the pain in
Sir,
shoulder
there is
during movement.
the whole of the humerus. Sir, the whole of humerus has not this humerus has no medullary cavity.
This is not the answer. The whole of the humerus has no medullary cavity.
Sir, I will prefer the.
Who told you this?
the
Abid, maybe you have read from somewhere, but whole of the humerus has no medullary cavity is not the answer for whether we can do nail or not nail.
For nailing, we have to make the for antegrade nailing, we have to make the entry around the shoulder, and
Okay.
there are more chances of.
This is the answer.
You know.
Yes. So in the upper limbs, plating is better than nailing. Okay. For us nowadays, we say that shoulder pain is more common than nailing.
Yes.
So here, this Chapman 2000, he said that plate is the antegrade I am nailing associated with shoulder pain and decreased shoulder motion. Okay, for example, my patient is a polytrauma patient, bilateral femur fracture with a humerus fracture. You will do nail or a plate?
We'll do nail. Nail
Why?
is
Why?
less traumatic.
Yes.
Uh,
Nail is less traumatic, but weight bearing is no problem. Either you do nail or a plate, weight bearing is not an issue. You can
okay.
give a reason in exam that I will do nail because it's less traumatic or something like this. It's okay, he will accept it. But in my exam, when I was given a humorous scenario, I said I will nail it because I want to emulate this patient. And he accepted that at that time. But now, maybe 10 years back, I found out that this thing started 2000. Effect of immediate weight bearing on plated fracture of humeral shaft. He quoted that when indicated immediate weight bearing following ORF of humerus diaphyseal fracture is safe and efficacious. So if I'm going for exam now, I will tell him that I can do a plate, no problem. As per text start 2000. Okay, who will tell me what is the classification for this fracture?
The nearest classification.
Nair. So what is Nair has defined it as a part. You know what is part? P-A-R-T,
Yes.
part. Part means
Yes, sir.
displaced.
Yes, sir. Angulation more than 45 and displacement more than 1 centimeter.
So he divided into 4 parts: the tuberosity, the head of humerus, the neck of humerus.
Okay.
The head of humerus, the shaft of humerus, and the two tuberosities, greater tuberosity and lesser tuberosity. These are 4 parts.
Okay, good. So how will you fix it? You can put actually there is a proper trial now. So you can do conservatively or percutaneous fixation. Already it's a known fact. But first time done was Jaberg et al. 1992. Jaberg, what it is percutaneous stabilization of unstable fracture of humerus. Okay, percutaneous. So this is the technique, and up till now this is the same technique, not changed. Even in our books, Campbell, it's written the same. So his fixation technique was two pin insert into the lateral cortex just above the deltoid incision and directed superiorly. Okay, one pin is inserted from anterior cortex directed into the humeral head. If the great tuberosity is displaced, it is reduced and fixed with 2 pins inserted from the fragment and directly inferior to engage the medial cortex. Pins should be widely spaced, means they should be divergent. Greater tuberosity pins are removed at 3 weeks and the remaining pins are removed after 6 weeks. So percutaneous pinning is technically demanding, but results are compared within or superior to previously described ORF methods. So if you want to fix, you have to do this fixation technique. This is the review articles. If you had time, you can read it. Okay, who will tell me indication for clavicle ORF midshaft?
There is a
One person.
Yes, sir.
Eunice, you can answer me if you want to answer.
yes, sir. Here, when there is a neurovascular disruption
Okay, good.
or injury and skin impingement and complete displacement means no contact between the parts.
Okay, yeah, very good. Good. But
What about a sportsman?
Displacement of more than 2 centimeter,
yes, yeah,
shortening of more than 2 centimeter, or fracture fragments or more than 3 fragments.
Okay, now let's refine this answer. Why don't we call it absolute and relative indications? Absolute is open, skin
Open
testing,
fracture.
skin testing,
Vascular injury.
neurovascular deficit. Okay. Relative is floating shoulder, shortening of 15 to 20 mm, and comminution. Okay.
Okay.
Yeah.
Okay.
Yes.
Bilateral clavicle. I have never seen bilateral clavicle. If you have seen, you can put it as a relative indication. No problem.
Yes.
So absolute are open, skin tenting, and neurovascular deficit. Relative is floating shoulder, shortening more than 15-20 mm, and comminution. You know who devised these indications? His name was McKee, 2012. He compared operative versus non-operative care of displaced midshaft clavicle fractures. Before this, we were conservatively managing. But 2012 was this a landmark article now already. So before it, they were quoting that non-union rate is higher in operative group than non-operative. So do not operate on clinic. But here he quoted that non-union rates are significantly higher following non-operative management than operative management, 15.5 to 1.4%. And symptomatic malunion rate higher following non-operative groups. Conclusion was operative treatment significantly lower rates of non-union and symptomatic malunion and an earlier functional return. And by the way, let me check if I have put that article. He also quoted that clavicle non-union does not cause any other problem, but there is reduced power grip in the shoulder, strength in the shoulder. So shortening, he was the one who quoted that 2.5, less than 2.5 centimeter, you should measure it with both clavicles. If the shortening is more than 2.5 centimeter, then you should fix that. And the displacement which he quoted was more than 100%. Like there should be one clavicle in between the two fragments. So he could, this is the, I think I put 2006 deficit following non-operative displacement shift clavicle fracture. He said good range of motion is achieved, no problem. The problem is that the strength of the injured shoulder was significantly reduced for all values. And he said that constant Muller score was 71% compared to the published normalative in general population, which is 92. So normal score is higher, CMS score is less than 85, I think. So it's called, it's known as a deficit, and 71 is a very low score. Who will tell me how will you debride this fracture, this location? You will reduce this fracture?
Debride?
Yeah.
Sir,
How will you, this patient came to the ER, what you will do?
sir, I would like to do the MES score, sir, first.
Okay, MES score done.
ATLS,
ATLS you have done, MES have done. You will reduce
wound
it.
wash
Wash. What you will wash with?
with normal
Pulsatile
saline and pyodine.
Okay. And you will reduce it in the ER or upstairs in the OR?
Sir, in the OT, sir.
In the
No,
OR.
in the OR.
Let's see some of the articles over here, then I will discuss. And by the way, I'm sorry, what type of lavage you will do?
The pulsatile lavage, heavy pulsatile.
High pressure or low pressure?
Sir, high pressure.
Okay.
Low pressure.
Abid, this was when I was going for exam, it was high pressure. After 2 years, I was in Ireland and I told somebody that is high pressure, and he laughed at me. And I checked the book and it was changed. And I throw the Campbell, I think so. I was about to throw it outside my home. That it's, they have changed their words. So what happens is, this is the day. In 2011, Petrisser, he wrote an article, fluid lavage of open fracture. It's a flow study, a multi-center blind factorial pilot trial comparing alternative irrigation solutions and pressures in open fractures. He concluded that low pressure may decrease the reoperation rate for infection, wound healing problems, or non-union. Before this, high pressure lavage was written in all textbooks. So now it is the book, low pressure lavage, not high pressure.
Low pressure.
Yes, okay. Pulsatile, no problem. Yes, pulsatile, low pressure lavage.
So we will go for a low pressure pulsatile lavage.
Yes. Yes.
Okay.
Regarding povidone or normal saline or hydrogen peroxide, see this. This was England 2005, comparison of soap and antibiotic solution for irrigation of lower limb open fractures, a prospective randomized study. He quoted, irrigation of open fractures wound with antibiotic solution may increase the risk of wound healing problems. And the conclusion was irrigation of open fracture wound with antibiotic solution offer no advantage over the use of non-sterile soap solutions. So, povidone, hydrogen peroxides these are of no benefits. By the way, in many countries, hydrogen peroxide, for example, if you're doing total hip replacement and you're washing the femoral canal, most of the countries, it is abandoned to wash it with hydrogen peroxide. Do you know this? It is abandoned in many countries. So if you are going, for example, you are going from here to France and you're operating, doing total hip, I hope, inshallah, some of you are good enough to do total hip replacement in France, going there as a visiting consultant. They will not allow you to use hydrogen peroxide to wash the femoral canal, because the end artery, they act as end artery, and it will decrease, it will burn the tissue over there. Okay?
Right.
So there is a saying, this is by, I think it was by Einstein. If we knew what we were doing, it would not be called a research, would it? So, like whatever we are doing, maybe after a year or 2 or 10 years, it will all be refuted. Okay. So that's it. So I hope you learned.
Well done, well done, well done, well done, Alamzeer. Well done. Well done,
Thank you, sir.
Alamzeer.
Thank you very much,
Shafiq,
sir.
how are you doing? You're welcome, Shafiq.
Well done.
Thank you
Well
very
done.
Okay.
Thanks a lot, sir.
Thank you, sir.
Thanks for your
Okay.
time.
It's my first experience on the Zoom, and
Ah.
I enjoyed it a lot.
Really?
And we hope that we can. Yeah, I enjoyed it a lot. Though I'm half sleepy, but I enjoyed it a lot. And I hope that many people will join it. It's only 12 people were there out of 200. Out of 200. So hope that these 12 people will tell others that they should join.
But
Well done once again.
these
Well
12
done.
people are more intelligent people, respectable people, so they are joining. So we are here for them, no problem.
Thank you.
Inshallah.
Thanks a lot.
Inshallah.
you, sir.
Inshallah.
Okay, good
Thank you.
job. Okay.
Thank you,
Thank
sir,
you
for
very
your
much.
valuable time.
Bye bye.
Thank you. Allah Hafiz.